Welcome to the May 2018 SurgeonMasters Web Conference, Surgeon Coaching to Enhance Wellness. A couple of SurgeonMasters Web Conference reminders before we begin. This web conference is being recorded. Discussion is designed to be open, but nothing is confidential. Please click Raise Hand if you have a question, or you can type it into the chat box for a response. Thank you. Jeff, take it away.
Well, welcome everybody to our web conference this evening. Appreciate those of you that are joining us live, as well as those that will be seeing the recorded version of this. I want to introduce our two main faculty members, which are Dr. Caprice Greenberg, who is the professor of surgery and the vice chairman of research in the Department of Surgery at the University of Wisconsin, as well as she's the director of the Wisconsin Surgical Outcomes Research Program. And our other guest faculty is Miss Michelle Mudge-Riley, who is the CEO and founder of Physicians Helping Physicians, and the president and founder of DocRD. Thanks for both of you for joining us.
Glad to be here.
Happy to.
So I'm also going to have some input on this. I often end up being the person with really good questions because I'm curious and inquisitive what other people are doing. But as far as the coaching is concerned, I do have a background as a certified professional coach, and believe that all three of us will have something to contribute to those interested in understanding how coaching might contribute to surgical performance, surgical wellness, surgical improvement, and managing the life as a physician or surgeon. And so glad we have this crew together. We're going to explore some perspectives on surgeon coaching. I think we share some principles, but hopefully by having our guest panelists still might define things or say things a little differently, and I think that helps put things into perspective where people can kind of understand and appreciate some of the different nuances and strategies that people can employ in coaching. I know in our introductory emails, we talked about one of the aspects of coaching, which is helping people set goals for themselves, to actually implement improvement strategies rather than just thinking and talking about them, and to also many times leverage our strengths in making our accomplishments to also then fill in on our weaknesses. I think that both of the panelists that I have been doing this long enough to actually have made some inroads, have gone through some own trial and error with working with different physicians and surgeons. And so hopefully they can share some of those perspectives as well. And I can certainly come at it from a little less experience, but certainly a vast experience of being a surgeon and an educator. And so welcome. I'm going to go ahead and transition to let Caprice get set up for her presentation. I think one thing I would say early on in this introduction, I mean, we do love educating and teaching on the subject, but I think one of the things is also getting people to take action. And so that action might be getting more education on these concepts, making a contact, learning more. But if you, in the process of either any of these presentations, also learn something that you can implement very soon in either a wellness strategy or your own goal setting, then please take the initiative to actually put that into action. On that note, I'm going to go ahead and transition over to Dr. Greenberg.
Great, thank you. So I come at this from a slightly different perspective. I, for most of my career, have been a health services researcher, and as such have been very interested in improving quality. And I don't know, probably about 8 or 10 years ago, realized that when we think about quality and performance, one of the things that we weren't thinking very much about was the role that we as surgeons play in the outcomes of our patients. So you can go to the next slide, Paul. In the United States, we spend about $2.4 billion and over 42 million hours per year on continuing medical education. And most of that does not actually directly relate to our individual practices and is unlikely to lead to practice change. And the futility of much of what we do in terms of continuing medical education and maintenance of certification has led to certain specialties actually starting to really fight back and say, we're not going to spend our time doing these things that have actually no meaning and no ability to improve our performance. At the same time, we know that surgeons are becoming increasingly burnt out. The latest data suggesting, 40% of us are burnt out and 30% of us screen positive for depression. And one of the things that leads to that is really a feeling of isolation in our practice, and as well as a feeling that a lot of the things that we spend our time doing are not the things that we became a doctor to actually do. So if you can go to the next slide. So what we're trying to do with our work through the Wisconsin Surgical Coaching Program is really to support a transition from our traditional approach to continuing medical education to a focus much more on continuous professional development. Under CME, it's really focused on summative evaluations. You complete your residency, you complete your fellowship, you pass your board exam, you're a fully mentored surgeon. And beyond that, up until, again, very recently, we have taken a recertifying exam, which is a test. And I personally am a practicing breast surgical oncologist, and I recertified a couple of years ago. And, I spent months and many thousands of dollars learning what was happening in critical care and vascular surgery and trauma and things that have absolutely nothing to do with how I take care of patients. And so what we want to do is move from that CME model where it's really being externally imposed on us as surgeons, the things that we learn in a very didactic setting, to continuous professional development, which is based on adult learning theory. Really moving to formative evaluations that are driven by each of us as individual surgeons, that are interactive, that take place in the places that we work, and that teach us and develop our ability to more accurately assess our own skills, identify our own goals, and as Jeff was saying, really set our own agenda for what improvements and changes we want to make in our practice, with really the goal of continuing our performance improvement throughout our careers. So if you can go to the next slide. I thought it was important to define coaching. I think this is one of those terms that right now, not only in healthcare, but really throughout our society has become very ubiquitous. And I think people use this term to mean many different things. So when I talk about coaching, I'm talking about unlocking a person's potential to maximize their own performance. We view coaching as helping people to learn rather than teaching them. And it's about providing objective and constructive feedback to help someone else recognize what works and what can be improved and inspiring them to maximize their potential. Next slide. When we talk about surgical coaching, we really talk about that in two regards. So there's expert coaching, which can be applied in resident and fellow training, or for surgeons in practice who are learning a new procedure. But most of where we spend our time is really in peer coaching, where peers who are at a similar level of knowledge and experience engage in an equal non-competitive relationship. And the goal really is to, again, establish individual goals for the person being coached, for both parties to observe them doing a task, and in our case, it's usually an operation, have them perform a self-evaluation, have the coach give feedback, and the goal is to improve task performance and support practice change. Next slide. To figure out how people can develop surgical coaching programs, we've developed a framework that really walks through the different things you need to think about in developing a coaching program within either an institution or really whatever level you're going to have your program at. The first thing you have to decide on really is the context. So is it going to be video-based, which is most of the work that we do, or will it be live coaching? Is it peer versus expert, as we just talked about? And then what level, institutional, regional, or national? In blue on the framework, you can see the things related to the coach, which you can actually control. So how do you identify surgeons who have the knowledge and experience to serve as coaches? But probably more importantly, how do you identify surgeons who have the interpersonal skills that are needed? The right communication skills, the adaptability, the ability to really switch into a co-learner mindset rather than somebody who is a teacher or an expert. And the greens on the side are the things related to the surgeon. And these are things that you want to control for, be aware of, but not actually be specific to your coaching. So the surgeon's skill level, their experience, the context in which they operate, those are things you really need to think about. And then the middle is really what happens, right? So at the bottom are the activities of coaching. And Jeff talked a little bit about this, right? You build a relationship, you set some goals, you ask good questions, you give feedback, and at the end, you come up with an action plan for actually doing something to change your practice. The focus of coaching, and if you can go to the next slide, is really on what constitutes surgical performance. And so there's these big blue arrows all over the place because all of these things are really interrelated. So technical skills, cognitive skills, non-technical skills, and stress management, which is something that has come up as we've started working with surgeons, that ability to recognize when you're stressed and then to have the coping strategies to deal with that and to engage your team to really help you deal when things aren't going well. And each of these influences your ability to function in each of the other domains of surgical performance. Next slide. So our approach really to coaching is that it has the potential to improve performance throughout surgical careers. It incorporates concepts of adult learning theory and coaching principles of co-learning. We approach it really as an opportunity to improve performance, learn new procedures, address variation in performance, and improve quality, safety, and outcomes. But really, the reason that this is related to wellness, which is the topic we're talking about, is it really is looking to change surgical culture, to develop a collaborative learning approach where we really engage as a community and recognize that we really have the opportunity to help each other to maximize and to realize our own potential. And my final slide. We are already making a substantial investment in CME without demonstrable return, and we have lots of different organizations through which we could support this type of approach to collaborative learning and surgical coaching. But again, it requires this cultural change where we move from our traditional approaches of autonomy and summative evaluations to one that's based on collaborative learning, individualized learning, and formative evaluations. So with that, I'll turn it over to, I guess, back to Jeff.
Yeah, thank you. And why don't we leave this slide up for a little bit while both Michelle and Michelle, feel free to chime in if you have any questions as well. You know, one of the questions that came up as you were sharing your material was the concept that, you know, it's a culture change, that we're also in, you know, kind of a point of transitioning that. How might you describe our level of transition across that spectrum from these two paradigms?
As a whole, like across the nation?
Well, you can break it down however you want, because it would be nice to hear if there was progress in certain areas that was more advanced. But sure, both as a whole and maybe in subsectors or things like that.
Yeah, so I think that this is, you know, when people first hear about the concept, talk about the concept of surgical coaching, the first response I really get from people is, we're already doing this. We do this. This is just a fancy new name for something that we've been doing forever. And then once you really talk about it, you realize that people realize that this actually is a paradigm shift. And I have yet really to have anybody push back really strongly on the idea, because I think that to surgeons it actually makes intuitive sense. And the question is, you know, well, yeah, why aren't we doing this? Why isn't this our approach to performance improvement and engagement? And I think that a lot of this really is the cultural change in terms of how we prioritize this, along with all the other demands that we have. as well as sort of working out the logistics.
And then in your experience, your program, what kind of inroads, or I always find that when people are leaders in a certain area, sometimes by the time others are jumping in, they're starting to make some really significant progress and changes. And I'm curious if you see any islands of that kind of progress.
Yeah, I think so. Our first program was in Wisconsin, and we had some major logistical challenges to it. The people that participated all gave us fantastic feedback on the program, and all really felt like it impacted their practice, and we're really happy with what they got out of it. We moved next to Michigan, and I think we were more successful in Michigan with this project, primarily because we integrated the surgical coaching intervention into meetings where surgeons already came together for other things. And so they were able to really begin to explore performance in a much deeper, much more qualitative way than we really ever have. If you think about morbidity and mortality conference and some of the other ways that we think about our surgical performance, it's pretty rare that we really get into our thought process in terms of how we plan our procedure or how we go about doing things. And I think, again, getting back to the ideas of wellness and satisfaction with work, I think that, for many of us over time, we get into this grind where we stop really thinking about what we're doing and why we do it. And I think that what you can see with these programs is that people really get back to the enjoyment of learning and being energized and continuing to try to optimize our performance in doing what we love.
Thank you. Michelle, do you have any questions for Caprice?
Yeah, so I'd be interested in hearing the perspectives of the residents versus the older physicians. Is there a difference in how they approach your program?
Yeah, so we have really primarily focused on surgeons in practice, so not very much on the trainees. I will say that there is more receptivity probably among junior people. I think people, when they hear about the program, often automatically go to the people that are newest into practice. It seems, again, like a no-brainer. Of course, we're putting these people out there after residency training, which we know is not preparing people to feel confident to go into independent practice without any kind of a support system. Where if you had a coaching program like this where they could videotape their operations and watch them and break them down and debrief with a trusted coach, that would be a really fantastic way to, again, get them to the fact that they are independent, but it's not that they can't ask anybody questions about what they're doing.
Mm-hmm.
But doing it sort of in a more structured way where it becomes just, again, an expected part of what we do. I think when we start practice, many of us do that in an ad hoc way with our senior partners, but I think a program like this would make it much easier for people to do it and make them feel, safer and more supported.
Do you get a lot of pushback from some of the older physicians?
No, we haven't really. In fact, the other thing I will say about sort of the generational divide is that we do have a lot of interest among people who are towards the end of their career and in actually serving as coaches, because many surgeons, don't really want to retire, but don't really want to keep operating, and it's a really kind of nice way to keep their hand in it.
Yeah, I can see that. I've heard that myself. Yep.
And Caprice, this is a little bit of a follow-up on what you've shared, from your involvement in the American College of Surgeons. And I know many of our audience are other specialties. They're orthopedic surgeons, urologists, plastic surgeons, neurosurgeons, and so on. Just within that organization, what do you think about the culture change or the incorporation of these sort of concepts?
Yeah, I mean, I think within the college itself, within the American College of Surgeons specifically, I think there's a lot of heterogeneity in terms of how people think about the concept of coaching. I think there's a lot of people who think about it in a very different way than the way that we're talking about it. And so I think venues like this and continuing to have sessions at the college where we hash out, well, what do we really mean by that term and what makes it unique and what makes something coaching versus not coaching will go a long way in terms of helping the organization to really define what it means. I think there's a lot of interest in collaborative learning. And as we know, that can have many different forms beyond just coaching. And so it'll be interesting to see kind of where the college ends up on this.
And I had the pleasure of hearing your panel discussion on that at the last American College of Surgeons as I became an inductee this late in my career to the organization. From your perspective, and this may be a hard question, I don't even know, but yes, there's a lot of different definitions. Do you think that there is a key couple of things that create the discrepancies rather than just the nuance things?
Oh, that's a tough question.
Because just to help you out while you're thinking,
I feel like this is a read my mind question.
Well, I mean, no, it's not even. It's just like I remember the discussion. It was things that were overlapping mentoring. They were, it was more layman's terms of coaching, whereas I think Michelle and I probably more appreciate your definition of coaching. Mm-hmm. And whereas I think that many people out there that don't know that much about coaching principles don't understand that aspect of it. So that's kind of, but I was wondering if, just from your process of having many of these conversations, whether certain key things come up.
Yeah, no, I think that that's exactly right. I think that there's a lot of confusion between mentoring and coaching. I think there's a lot of confusion between teaching and coaching. I think there's also this concept of, for lack of a better term, I'm going to say peer support, but this idea of when people are going through a rough time, providing them with support and resources to get through that, which you can do that through coaching, but I think there are also many other ways that can be done. And I think there was a lot of overlap of those concepts during that particular panel. And I think that panel really reflected what my experience has been within the surgical community. I mean, I think that there are people who are at very different levels of their understanding of what coaching means. There was a great.
I could attest to that. Absolutely. Yeah, I hear that all the time as well. So. Mm-hmm.
Yeah, there was a really interesting paper that was in the Annals of Surgery, and I mean, again, I'm coming at this from a researcher standpoint, but they did a qualitative study in Canada and asked practicing surgeons would they be interested in coaching, and the overwhelming response was no. And then Mary Klingensmith, who's the current chair of the American Board of Surgery, and I wrote an editorial which really pointed out that all of the reasons people said they weren't interested in coaching just showed that they really didn't understand what it was. Right, so it was this idea of maintaining control over their learning and the idea of having autonomy, and everything that they sort of brought up as barriers to coaching really was actually quite consistent with what it is that coaching tries to do when it comes to performance improvement.
And the other reason I think there's potential confusion is that I think that some hospital systems have integrated the concept of coaches into the way they bring people on board to various policies, procedures, JACO requirements, hand washing, all sorts of different things. And I think that they mix what many of the things they're actually doing is teaching and trying to get compliance, whereas I think many of your coaching model tries to help the physician or surgeon steer their own performance improvement through guidance.
No, I think that's exactly right. And that gets into sort of a lot of the, system redesign and primary care redesign, which was based on, the concept of practice coaching, which is different than the type of coaching we're talking about. The other place I've seen people bringing in coaching is when people have really poor patient satisfaction scores, and bringing it in a very remedial way of, okay, well, we're going to help you with, your interpersonal interactions with patients through coaching. And one of the things that we've been very, very adamant about is that coaching, as it's introduced, again, because it is such a cultural change, really needs to be introduced in a constructive, across the board kind of way, as opposed to a punitive, remedial type of intervention.
Thank you. Those are very helpful responses to my questions. Thank you. So Michelle, Dr. Mudge-Riley, can you go ahead and share some of your information, and we'll get your perspective on some of the ways that you've been involved, both as a physician coach, as well as potentially interacting with many clients that might be on the surgeon side, but maybe also having the perspective of some of the things you've learned from those that aren't.
Sure, yeah, thank you. So I come at this from a completely different angle, much more practical. And my background is not as a surgeon. I was trained as a pathologist. So I did interact with surgeons, and about 40% of the people that I work with on a daily basis are surgeons. So I have a lot of experience there. My background is also that I have a master's degree in health administration. So I kind of take that angle as well, and know a little bit about what some of those at that level are looking for, and why coaching may be put into place within a hospital system. So I not only work with physicians one-on-one, but I also work with them within various hospital systems. I am not affiliated with just one hospital system. In fact, I have clients all over the country, on the East Coast, West Coast, Midwest. So it's interesting to see the similarities as well as the differences, and there are mostly similarities that I see. So if you'll just go to the next slide, we can get started talking a little bit about, and you can just skip this. All right, so I start out kind of talking about this burnout issue, and Caprice, I know you mentioned this too. This is a big deal. Many physicians are burned out, or if they're not burned out, they're not happy. And most of my experience has been either with physicians who are thinking about leaving medicine entirely because they are not happy, or there's some reason why they're not fulfilled or satisfied by practice, or the organization has mandated that coaching must be put in place for them because there has been some sort of incident. And what I've seen over the past decade in doing this is that more and more physicians are being targeted, and that can be for whatever reason, but peer coaching is often put into place for those physicians because they haven't been doing whatever it is the hospital system is looking for them to do. Next slide, please. So again, my experience has been with this peer coaching. I've been doing this since the mid-2000s. About 2006 is when I really started actively working with physicians almost on a daily basis. And that was more helping them to transition into something different, whether it's figuring out what their career strategy was going to be and staying within the organization and maybe becoming a leader or working within administration, or whether it was changing careers entirely and doing something different, sometimes leveraging their medical background, but not always. So setting action plans, objectives, goals, all the things that you talked about are things that I've worked with physicians to do, and things that we talk about on a daily basis in terms of figuring out what it is that you want to do. Now, when I'm working with physicians in hospital systems, I use the same techniques, mainly because I want to also help them to put metrics into place for themselves so that they can have some tangibility to this peer coaching. One of the problems that I see is that it is mandated for them to undergo peer coaching, yet there are no metrics in place. And so at the end of the day, who's to say whether this peer coaching has been successful or not? And that can be a major problem for the physician particularly, because if he or she is being targeted for whatever reason and then goes through this peer coaching, how does one show progress? How does one show that something has changed? It's very interesting, but that's a big topic of discussion for me with the physicians that I work with, is talking about what those metrics might be and how to put them into place, as well as how to talk to the administration about that, so that for whatever reason they're being required to do this and it's going into their record, then they also have a record of what they've done positively, and that also is something that I help to get in their record. All right, go ahead with the next slide, please. So I know Jeff wanted to talk a little bit about health coaching, and in addition to the peer coaching that I've done over the years, I also have another company where I do health coaching, both with physicians and patients. I started this company in 2014, and because I also have a dietetics degree, I mainly concentrate on nutrition and preventive medicine type of coaching, I guess. I do micronutrient testing and food sensitivity testing, and speak with people about how to just become healthier in general. Part of my background is in corporate wellness, so that's part of where the health coaching comes in as well. And that is work with employees on keeping them healthy, getting them healthy, keeping them healthy, and then again, putting metrics into place so that one can measure how effective the program has been. Next slide, please. So I don't have many slides because I'd really like to just start a discussion here. That's how most of my panels and workshops go. What I find is that answering the questions of the people that are watching, or starting a discussion with you guys based on what you've seen and what your questions are, is really the most helpful for the audiences that I've been in front of. So keeping that in mind, Caprice, do you have any questions based on some of the things that I've done that I just talked about now?
Sorry, I had muted myself. So one of the questions that I have for you actually is, as I was listening to you talk, you said that a lot of the people you work with, they've been mandated to coaching. And I think one of the principles really is this idea of autonomy and willingness to participate in the process. So how does that sort of motivation versus being mandated play into your interactions with your clients?
Yeah. So it's a tough situation, really. Most of the physicians that I end up working with that have been mandated to do this are not excited about it. So I am often working with people who just want to get through it, or dot some I's or cross some T's and get through it. And the challenge is to not only help them become more self-aware, but also enable them to participate in their own growth and self-discovery. And with the ones that I can work with to do that, the coaching is very, very positive, and they end up telling me they get more out of it than they ever thought. So at the end of the day, I'm more interested in helping them to get to where they need to be, whether it's within the health system or themselves. But that's a pretty neat thing. It's kind of an unsolicited type of a response, but something that is a good thing for them. So are they glad that they went through it? Yes. Do they wish that Sorry. Hi. All right, bye. Sorry, it's nighttime here and we have kids. Um, anyway, so it's usually a good thing at the end of the day as far as what they got out of the coaching, but that doesn't happen with everyone.
Yeah. No, and I think we've had that experience too, where, several people have said going through this coaching just made me a better person. It helped with my marriage. It taught me how to listen. I mean, because there's such few things that we actually participate in today that really are all about looking at yourself and trying to figure out how to get better.
Right, exactly. And a little bit of that is fluffy, and physicians generally don't like that, which I can completely empathize with because I don't like that either, particularly surgeons. Most of the surgeons I deal with are very to the point, black and white. They just want to either get through it or figure out what it is they need to get and then do that. But they're often the ones that end up much happier because they've figured out just something that maybe either they weren't paying attention to or that they should have been paying more attention to.
Yeah, and wouldn't you say, I mean, they're sometimes it's integrating pragmatic strategies that they can buy into a little quicker to then also have them almost do their own little controlled experiment where when they do it, they start to notice other things that might end up being described in retrospect a little bit more fluffy, in the sense of improved communication, getting more smiles from people that they interact with than the frowns and people trying to avoid them, or different things like that.
Well, interestingly, they don't think those things are important at the beginning. And in the grand scheme of things, are they really? I mean, when it comes to saving a patient's life, they're not as important. But once they sort of buy into the process and are able to go through a little bit of it themselves, sometimes it helps them to return to what is important at their core, and they start to make discoveries about themselves that they hadn't before. So I've often seen them report that their marriages are improving, that their health is improving because they've started to pay attention to the things that they weren't paying attention to. Their relationships are improving, so not just with the staff and the nurses and maybe with their peers, but all around and with their kids. So it is very interesting, and most people that go through the process end up feeling like they become more human and more, I guess, less academic in a way, which to them is sometimes welcome.
Thank you. You talked a little. You did mention, and obviously we don't have time to go into a lot of detail, but the concept of metrics. And I think that several of the people that I collaborate with, and I would probably put Dr. Greenberg in this category. When it comes to demonstrating effectiveness, the metrics are really key.
Yeah.
In your models, what metrics have you been able to really be successful with?
Yeah, that's a great question. And it really depends on the person's situation. But what I try to do is put some sort of tangibility around what the individual is doing and what it is the organization is looking for them to do, or where they're looking for them to be, whether it's improved patient satisfaction, whether it's increased positive relationships with the staff, whether it's increased efficiencies with their charting, whether it's taking time to slow down a little bit, because I work with a lot of surgeons who are highly productive, but often, quote, get into trouble because they don't take the time to slow down and talk with some of the nurses about what's going on and what their orders are and how to implement some of those things. So taking whatever issues are at hand and thinking about how do we put objectives into place and something that we can measure, so that not only you know that there's improvement, but the people that you're looking to complete this program for also know that there's improvement, and get that written down or get it recorded somehow, whether it's through a conversation. And that's another thing too. Oftentimes surgeons and all physicians really are too busy to really communicate that the metrics have been met. And so that's something that we always talk about, is what is going to be your strategy for making sure this is communicated. And that often depends on the individual, the organization, what's really going on, whether there's a written record or not, whether there are regular meetings or not, and all that's part of this.
And just to give you a little bit of opportunity, because I know you have clients that don't come in to you in that sort of realm. What other, where it's more voluntary, what general experiences with surgeons?
Yeah. So interestingly, there are a lot of surgeons who either don't want to continue what they're doing because they're bored. It's become a monotonous thing. They've done a really neat procedure over 100 times. And so they're ready for that next challenge, and they're not quite sure what that is, but they need help identifying it. So we work together to figure out, all right, what are your options? What are different ways that you can leverage your background and training? What do you enjoy? What was your specialty, whether it's cardiothoracic surgery, whether it's neurosurgery, whether it's orthopedics? And how do you take that and utilize that in a new way? Is it within biopharma, pharma, utilization review work, administrative work, leadership work? I mean, there's so many different ways that people can use the skills that they have just in a new way. And that gets surgeons very excited. The next challenge then is, okay, well, how? You know, what do I do? And then we get to talk about things like networking and reaching out to people and figuring out where people are doing innovative things, whether it's at a company or whether it's within their own organization, or whether it's them starting something new, or even looking at some sort of invention that they've always had a thought about. So that's very common, as you can tell. I've done that more than once.
Mm-hmm. Well, thank you. So in the sort of last third of our web conference, I'm going to go ahead and let Paul shift into my slides. I actually am going to continue the question and answer format by using kind of some of my keywords, and so I'm going to go ahead and go with the next slide. So one of the things that I've done is created kind of a methodology, and the methodology is not as important as it's kind of a checklist of 8 sort of things that somebody can do to evaluate whatever they're trying to deal with to create performance improvement. And so the P part of practice is a passion for performance improvement. And certainly it kind of brings in both components, the concept of figuring out your passion. Michelle, you shared that one of the issues can become for surgeons is that they're losing their passion from either boredom or some other aspect. And, you know, when you're trying to inspire people to have this peer coaching, even from the surgical realm that Caprice talks about, if they're not, you know, what you'll find with any adult learning theory is if the person isn't really motivated, they don't have a why they want to get better at something, they're not going to put a lot of energy into it. And so I imagine that both of you have as a component this sense that people have to find what they can commit to, where they can create a passion in their learning and in their careers, because I think it's that passion that drives people away from burnout and more towards wellness. That obviously was more of a statement than a question, but any comments on that? Michelle, why don't you go ahead?
Yeah. So that passion is huge. And I find that's a primary motivator for seeking out coaching, those that come to me willingly. And having having an interest, and passion is sometimes an overdone word. You hear that all the time. So having just a strong interest is very motivating. But that's the passion aspect, and the interest in self-motivation is one of the techniques I use for those who are mandated to do this coaching. So we really figure out what it is that drives the person, and by understanding that, and it usually does relate back to something within themselves that they feel like is lacking, whether it's something that they haven't ever pursued, some sort of idea or an interest in their professional lives, or maybe it's a health related thing where they feel like they've just really let that go and they're very interested in kind of getting that back for whatever reason, or maybe it's a relationship side. So looking at what it is that drives them is a very big key in motivation for them, whether they come to me willingly or not.
And my timing might be, why don't we go to the next slide? So in reciprocity and roles and relationships, here, when if you think of sort of the coaching model or the coaching role, I kind of consider this one of those other things that's key in coaching, that, each person, whether it's the peer coaching model, or which is, I think, a lot of what Caprice is doing with her program, that there's a give and take. And when you can kind of find that reciprocity of that give and take, that it creates a effective model. And sometimes it's teaching the skill of actually knowing in each of our situations that we have to actually appreciate that give and take. Where do you, Caprice, if in this one I may have to explain a little bit better, so I'm open to that aspect, but do you find that as an important part of the coaching program there in Wisconsin?
So I think that this is actually one of our biggest issues. Surgeons, they like the idea of collaborative learning. They push back on the idea that somebody has to be the coach and somebody has to be the coachee. And so they want to know why they can't just be peers who are sort of learning together. And I have to say that when I first got into this area, this was something that I struggled with a lot as well, is if we're peers, can't we just, equally learn from each other in the same way? And I think one of the things that makes coaching unique, and Janet Dombrowski, who's the executive coach that I partner with, has really taught me this, is that, somebody has to hold the space. Somebody has to say, okay, we're going to set the goals now. And somebody has to say, okay, what is our action plan going to be? And somebody has to hold accountability for making sure that something actually comes out of the time that you spend together. And so I think figuring out the roles and responsibilities during a coaching session is very important, especially when it's peer coaching and when you have a surgeon playing the role of coach and a surgeon playing the role of coachee. Being very clear about what that relationship is. The fact that somebody can be a coach and not be in a hierarchical relationship with another person is kind of a real change in mental model for surgeons, because it's not the way that we traditionally think about coaching, and it's not the way that we traditionally think about interacting around learning.
And I think, and I agree. So that, one of the things there that you highlighted is, if you don't understand your role in a relationship, that there's confusion and it's going to be a less productive relationship. And even if that role can be swapped, from time to time, I think one of the advantages of some of the concepts of group peer coaching, and maybe even in your model, is that when somebody has a little bit more experience or a perspective where they're functioning more as the coach on one aspect, that those roles might switch on another topic or another situation. But again, knowing kind of who's typically taking each role can make a big difference on the effectiveness of that relationship.
Yeah, and I think in our model, we really try to have our coaches also participate as coachees. And so really we have defined periods of time where people are interacting. And so switching those roles between those different sessions is easy to do, but making sure it's defined who's in which role during a specific interaction, I think is really important.
Thank you, Paul. Why don't you switch to the next slide? So attitude resilience is means a lot of different things. One of my definitions is my opportunity to kind of help people learn that a positive attitude is very effective. I think one of the things is also that Michelle pointed out is that, and my theory is actually some of the teaching models or the expert model where somebody's saying this is how it's done are highly effective in surgical training. I also think that you don't necessarily wait for a kid to burn themselves on the stove before you shout at them to avoid it first. So negative training strategies play a role. They particularly play a role in high stress or high stakes situations. But then when you are doing a routine case and you're doing a case that is going well or going routinely, that you don't necessarily have to then model those high stress situations. You just maybe have to shift gears when it gets to that point. So I think that the attitude or trying to balance out some of those skill sets that we were taught and realizing that there are a lot of positive attitude things that people can do and that they can build up their positive resilience using positive strategies can be very helpful as well. Some of this is also kind of this concept of whether a glass is half empty or glass half full. And when people approach things always in a deficiency mindset, that builds on itself and becomes a little bit pervasive. And if you can measure performance improvement, not as to how far you are from being good at it. I think Michelle even said that, we talk about things that we notice that we're deficient in. And part of the problem is that we're sometimes over measuring or having a very high expectation in performance improvement. And when you set the bar so high, there's sometimes a response of the learner or the coachee that, well, I can never achieve that, so why would I try? And so I think it's trying to help set that bar. And I think even in one of your diagrams, Caprice, you showed that as kind of helping their starting point, right? And assessing where they are in their starting point. And if you know that in the beginning, then it's a very effective strategy to transition them to the next point of their learning. And again, I'm making statements more than I'm asking questions, so I apologize. Just any comments on how you've integrated any of those strategies in your programs?
Yeah, let me respond here because it's important that to me and to the people that I've worked with over the years, the positive attitude, the positivity is a huge, huge thing for them. There's often a very pervasive feeling that there's a malignant culture within medicine and we're just not very nice to each other, which I have experienced myself and I've seen it with others. So bringing that positivity to the situation and trying to sustain that and teach others in how to look for that and sustain it in their own lives, in their own practice and how they approach things has made a huge difference for most of the people that I've worked with. And in workshops where I'm talking to hundreds of people, it's something that is a resounding yes, yes, absolutely, every time I talk about it. So I'm glad you brought it up because I do think it makes a very big difference in the people that I have seen and talked to. Caprice, I'd be very interested in hearing your perspective, though.
Yeah, I think the place where I see this the most in our work is around teaching people to understand what constructive feedback is and the fact that constructive feedback does not mean negative, right? It means specific, it means actionable, it means something that somebody can actually understand what it is that you're seeing and trying to describe to them. And so getting people to reinforce what people do well as part of coaching and not just help them to identify the places where they could improve, I think is a really important part of building this positive attitude.
Yeah, that I would just repeat that point on how people appreciate feedback because it's really key. And when you actually see models of people giving feedback and seeing the recipient of it accept it, and you're in the audience or you're observing it and you're saying, wow, I don't know if I would have taken that as well as that person did, but when you see people model it, it's pretty impressive to take on that mentality. Paul, why don't you go ahead and go to our next slide? And Paul's helping me keep track of questions, so some of these I'm integrating into the conversation as well. Just the communication with mutual understanding. And you know what I'm going to do, just because we have 4 minutes left on our web conference, I'm going to just kind of hit these and leave it for our panelists to kind of comment on any or all of them if they want. But the principle that learning listening skills is very important. Being an effective coach, being able to listen is very, very important. But in this sort of peer mentoring and adult learning theory, that in order to effectively communicate back and forth between those two roles of the coach or the coachee, that often there is a need for that back and forth conversation, because there's many times where I've been coaching a surgeon and the initial explanation or conversation of or a teaching point that I'm trying to share isn't totally understand. When you have that back and forth, you'll get to a point where of a much greater mutual understanding of what's understood and what's not understood. And then on the next slide, time life management using rhythm. And again, here is just kind of whether it's a coaching relationship, whether it's establishing what many people talk about as life balance, but realizing the very busy schedules of many surgeons, that often they're not really striving for balance. They're striving to be in their rhythm where they can step in and out of their different roles to just be effective in many of those, whether it's being a parent, a sibling, a chairman, chairperson, program director, or businessmen. Again, people being in both academics and private practice. And then our next one, inspiring others' shared goals. Again, this is a lot, I imagine, in hospital models, program models, that if you can inspire people to, you're going to inspire them best by finding out what those shared goals are. I imagine in people that are mandated to coaching, that trying to figure out where they actually share a goal and the outcome is key to making that an effective relationship. And I'm just highlighting on some examples. And then the next slide. Complex problem solving through simplicity is, again, looking at, many of these things are complex, but taking one step at a time or finding a few aspects to move forward on is one of those principles. And then after time, and if you have a longer term relationship, often you can make some significant changes. Go ahead, Paul. You're on me. You're good. Go to the next slide. And then kind of the full circle is kind of when you have a nudge in a direction of improvement, that, practice wellness can be raising your surgical skills. It can be a more effective surgeon in the broader term, not just in your technical skills, but in your ability to make a case go well in many other ways other than just your techniques with your hands. That will then set you up for the next thing that you're working on in your performance improvement, or it could be in a health issue or many other aspects of wellness in practice. Any closing comments from our panelists, Caprice or Dr. Greenberg?
Yeah, I mean, I guess I would just say I'm really encouraged by how open surgeons have been to the concept of coaching and collaborative learning. And I think that we are just seeing the beginning of this cultural shift where we're going to eventually have this be the norm, that people interact in this way and that it's viewed as a very positive thing.
And Michelle or Dr. Mudge-Riley?
Yeah. So I'd like to echo that. I agree. And reaching out for coaching or being very accepting of it is a trend that I've seen over the past 5 to 7 years, really evolving. It wasn't always that way. It wasn't always that physicians were open to coaching or even interested in it. And it was Atul Gawande, I think you mentioned him, Jeff, in one of your slides, that really did a great job talking about coaching and the power of it and communicated it out to the masses. But that wasn't the only thing. I think there's been a movement just across many different health systems and in different in different organizations that has helped coaching to be seen as something that's positive versus punitive.
Well, I thank you so much. I think one of the things that I look forward in my concept of even time management is that the nice thing is that these things are not isolated. This is one single event in a process of collaborative learning and adult learning. And so I hope that you guys are open to any of our participants that might not have spoken up on this web conference. They might speak up in a follow-up email or conversation either through us or directly to you, as well as those that are going to listen to this in a recorded version. So thanks so much for joining us. You guys were outstanding, and I appreciate your time.
Thanks so much.
Good night, everyone. Thanks for joining us, and look forward to you joining us on a future web conference or many of the other things that we've been doing with SurgeonMasters to educate everybody on these issues. Thank you. Good night.